So a cardiac cath, either through ischemia or possibly, through clot, through clot,
Oh, absolutely.
will cause a rise in enzymes.
Yes.
Would you consider that? Would you call that a heart attack, or what defines that as a heart attack?
A raised cardiac enzymes count as a heart attack. The general time of what we call a type 2 non-STEMI, which basically means that the enzymes are going up. It's the equivalent of if you're running and you're running too long and the next morning you can barely move and you've damaged your leg muscles. Well, you're going to make enzymes, but leg muscle enzymes as opposed to or skeletal muscle enzymes, not heart enzymes. They're going to repair themselves. If you go into atrial fibrillation and your heart rate is 200 beats a minute, and you have slight blockages, but not bad blockages in your heart arteries, you won't get enough oxygen and you will kill off some myocytes, and it's a very sensitive test. Was there ever a blockage? No. Was there ever a clot? No. It's a demand ischemia. And it can also occur with severe anemia, sepsis, hypotension, anything that decreases the amount of oxygen
delivery. The heart is that dependent on oxygen.
Will cause the muscle cells to be damaged. And the point with if you have significant coronary disease and you're just doing a diagnostic heart catheterization, you should not have a bump in elevation in heart enzymes. If you have had chest pain and you're going into the cath lab because you've had chest pain, well, you might have had a small clot which is now lysed, perfect example with that study that I was talking with Nick about on the alleged rapid progression of disease. So something could have been there, and then it lysed on its own.
So let's get back to the arrhythmia. So now you've got your atrial fibrillation.
Yes.
You've done your ablation. And is there any contraindication to an ablation?
If you're not going to live for a year.
Okay.
And the basic indication for an ablation is this going to make you live longer, or is this going to make you feel better?
So most people feel crappy when they're in atrial fibrillation, especially rapid.
Again, if you are well controlled. In fact, the new guidelines are very specific on it is a class 1 indication for pulmonary vein isolation. That's an AFib ablation for people that have symptomatic atrial fibrillation. It absolutely can be considered for that.
And is that usually related to the heart rate?
Yes, but not always. There are people that are out of rhythm, and we in the past used 70 as a cutoff. If you're over age 70 and your heart rate is controlled, you're nowhere near that.
No. My brain is racing. You throw one thing out, I think of another question. So okay, sorry.
So if again, generally, if you were over 70, your heart rate's well controlled, you feel good. There's a strong argument for leaving well enough alone. Because yes, you are doing procedures where you're burning and you're punching holes in someone's heart, usually 2, and they heal, but still, those are serious.
You got to punch a hole across the membrane of the heart to get to the other side. Yeah, that's like so you create a PFO.
Yes, 2 frequently.
2,
but they'll close right up.
Yeah.
So that's not a big deal. Ideally, when we do a procedure, we want someone to live longer or feel better.
What's the complication rate?
Nowadays, it's much, much lower than when I was doing them all the time.
20%? 30%? No, I'm kidding.
No. Realistically,
what's the
1%.
1%. So you got a 1, and that's what would you call a complication? Death or?
Of all things together, the most common complication is a pericardial effusion.
Fluid leaking out.
Because of with the transeptal or from the burning or from the freezing.
And is that from edema or is it bleeding?
They're actually from a connection from the inside of the heart to the outside of the heart.
Right, so that's bleeding.
Yes.
That's blood.
And does it require someone like you sometimes to put a little purse string
window
in?
Or close the hole?
Usually it's not a little window.
Yeah, so it's closing the hole.
Yeah, it would put a pigtail catheter in to suck out the blood. It's rare. It's a fraction of a percent. And it's usually people that have many comorbidities.
Right.
Or are somewhat older.
So, but pretty much you're telling me that if you've got atrial fibrillation, the right thing to do is to get an ablation.
Generally. If you have symptomatic
wait,
fibrillation.
let me back up a little bit. What about cardioversion?
Well, cardioversion is the first step generally. It depends on what the risk factors for and depend on your age. If you are a 35-year-old guy, came in atrial fibrillation, doesn't have a thyroid problem. His echocardiogram looks good. Aside from his left atrium's a little on the big side, and his mother and his dad both had AFib. This is a guy that most likely with some medications will go back into rhythm. If he hasn't and he's still in the hospital, you cardiovert him.
So are you going to cardiovert chemically or
electrically? That depends. There is a medication.
Adenosine?
Well, no, adenosine works for atrial fibrillation, but ibulide is another medicine you can give over a relatively quick period of time in the hospital, put it back into rhythm, and you need to watch them for a few hours afterwards. Right. We tend not to do it quite as much as do a regular cardioversion. But a lot of times in this young, healthy person, you give them some beta blockers.
Do you have to put them to sleep to do that?
Yes.
So both.
No, not for the.
No, I know the ablation you do, but not for the chemical.
For cardioversion, yes, it's a very brief.
Right. No, but what I'm saying is, if for the chemical one, for the medication.
No, you don't.
Right. So if you are a high anesthesia risk,
yes,
you go medical rather than
right.
ablation. Yeah.
Mm-hmm. Yeah, but the thing is, the chemical cardioversion with that medication does carry some risk of certain other hard cardiac arrhythmias for a few hours afterwards, so you need to be watched very carefully. But while with the cardioversion, you give the electric shock, that's it, you're done. As soon as you wake up, you can go home.
And what is the success rate of that?
That depends. If a young, healthy person that only has slightly elevated left...
Typically somebody in their 50s and 60s that has metabolic syndrome.
Okay. So I'm sticking with the 35-year-old first. 98, 99%. For someone with metabolic syndrome, he's probably going to have an enlarged atrium, normal pump function, normal pulmonary pressures. The success rate without medications for 30 days, meaning you can go back into it, you're probably going to be about 80% chance you're going to be in it when you walk out.
And you talk about transcutaneous.
Yes, transcutaneous. We use pads now.
So you basically shock them and you stop the heart and then you wait for it to rebeat.
Exactly. The thing is that at 30 days, now comes to be the issue. Where are you going to be back in atrial fibrillation or not? And
do you always put someone after electrical cardioversion, do you put them on medication to slow the heart rate down? Do you medicate them as well?
Yes, unless there is a very specific reason. Generally, there's going to be a reason, and the odds are good you are going to go back into atrial fibrillation. It could have, unless, of course, it was post-operatively or due to sepsis.
But if you just come into the ER, you're short of breath,
and you're 50 years old, then we will give them anticoagulation.
Which, so I want to talk about anticoagulation separately. So you don't anticoagulate them.
And I will normally give them at least a beta blocker or a calcium channel blocker so that if they go out of rhythm again, their heart rate may only be 100 as opposed to 150.
Which do you prefer?
Beta blockers or calcium channel blockers? I generally prefer beta blockers because people tend to be hyperadrenergic, where calcium channel blockers like the diltiazem and verapamil are going to do nothing for your anxiety, your adrenaline.
Right.
And adrenaline absolutely can trigger off cardiac.
If I walk past the donut, I'm going to gain 5 pounds. So one of the things I've changed, apart from being on a ketogenic diet, I like to suppress or reduce caloric consumption. But as you know, you never want to white knuckle your way through a 48-hour fast. So there are times when it's easy and it's straightforward. There are times when I'm really dragging, particularly if I'm not in ketosis where I'm exhausted. That's when I'll use a ketone IQ. Ketone IQ, SHERYL and myself have found, is the best formula to rapidly promote a ketogenic bloodstream. Where I've got ketones in my blood work, not a big spike, but a gradual rise that lasts about 5 hours. But the time I most struggle is in the evening, when I'm about to have dinner, but I don't want to have dinner, and I'll hit one of these guys. It'll help me to cross to the next day. If I'm in ketosis the next day, I'm good to go. I strongly support ketone IQ to help you through your fasting. So now let's talk, so you cardiovert them, and then if they flip back in, you can cardiovert them again or take them to...
I generally would not. If I give them the option, if we have no history of this, your atrium isn't that big, and there may have been a triggering cause, I said, let's wait and see. We'll keep you on anticoagulation. We'll give you a little beta blocker, see what happens. We will do...
In atrial fibrillation?
No, in normal rhythm.
In normal rhythm, okay.
Yeah, we want to try to get people new onset. We want to try to get someone into normal sinus rhythm. The question comes down to, and this varies between the doctors, EPs tend to put people on antiarrhythmics because they had to come to a hospital. They weren't
What
happy.
is an antiarrhythmic?
An antiarrhythmic is a medication to help
Just
keep
some
you
names, but some
in
names.
rhythm. It is Multac, amiodarone, flecainide, Rhythmol.
Okay, so those are the ones, because I see patients on those,
Right.
and the patients often don't know I'm on this pill,
Yeah.
what does it do? So that's what, those names, that's what they
Among
do.
other things, it's for atrial fibrillation. It can be for ventricular arrhythmias, for SVT as well, too. I tend to put people on antiarrhythmics and leave them on it for a while and then say, okay, you stayed in rhythm. That's great. Why don't we stop the antiarrhythmic and see what happens?
Right.
While if I put them on an antiarrhythmic and then they go into atrial fibrillation again, even if the rate is slow, I'm like, well, you need an ablation because I've given you
So the next step
medical
is,
treatment.
okay.
And so I prefer that because if I would not put them on an antiarrhythmic and they go back into AFib, well, then sometimes the insurance companies will say, hey, you didn't put them on an antiarrhythmic. We're not going to let you do an ablation.
Right.
So now you go back and do it again.
Economics.
So that's an
So
argument
let's
for
talk
that.
anticoagulation, because there's a variety of different ones, starting with the old warfarin and aspirin. Why don't you take me through the different classes and the different indications for the various anticoagulations? And all the anticoagulants interfere with the fibrin clotting cascade up to platelets.
Yes, except for platelets.
Well, aspirin interferes with thromboxane A2 inhibitor. That's what I'm saying. From the beginning of the clotting cascade all the way through to platelets. That's what the anticoagulants do.
Right. So basically, they work in two different ways. There are, and cardiologists will differentiate the difference between antiplatelet and antithrombin, or anticoagulation. So if you have a stent we will give you antiplatelet agents, but not anticoagulants. We will give you aspirin and something similar to Plavix. There's Brilinta and other medicines now, because the clots that form in the stents, whether they're bare metal or they're drug-eluting, will be prevented for the most part. Like
Antiplatelet.
Antiplatelet agent is.
Well, it's not so much they get prevented, but they don't stay.
Yes.
You're forming clots all the time, but they dissolve.
Right, and they will
the
not.
Thrombolysis
They will not stick to the stent.
Correct.
And which is a different. Those are again a different type of clot than the red clot. Those are more considered white clots. The red clot is the thrombin rich, which can occur with atrial fibrillation because there's a little area called the left atrial appendage, and it forms eddies. And when you're out of rhythm, we can see it on the transesophageal echo. That's where you do the echo, but instead you put a little garden hose down, and they're nicely knocked out. And then you can see, because it's only a couple of centimeters, and you get a beautiful view.
That's what you're saying. You could clip, or you could put a watchman in there.
But the main
but I mean the cardiologist clips in the combination procedure.
Yeah, but the reason why you do it is to see, is there a clot there?
Right.
If there is no clot, then we can go ahead and cardiovert. If there is a clot, then
I see. You don't want to get right.
Because if you put somebody to normal rhythm, and now that atrial appendage that's quivering now starts to contract,
and that can
it can squirt the thing out, and that's not a good day.
But let's say that you've cardioverted somebody and they're successfully out of. What is your regimen for anticoagulation, and which are the anticoagulants that you would use? Because they function on different factors.
Right. Yeah. There's basically three different types. The old-fashioned is warfarin or Coumadin,
which very few people use.
Yes, we try not to. It has really, its only true indication is for mechanical valves nowadays, or somebody that has failed other months. And it has a downside.
The VA still likes them in some states.
Oh yeah, because it's cheap in some respects.
Right.
Speaking as a veteran, I can understand their perspective, so it's not really that cost effective anymore because of the complications, because of the fact that it has to be checked all the time, and you're spending so much time out.
And it's miserable for the patients.
Yeah. Absolutely. It's better than nothing, but it's not preferable.
Right.
And nowadays we can pretty much get the newer medicines, which can out of pocket, $400, $500 a month.
Well, they've just reduced cost, but let's talk about the efficacy. Forget about the cost. What are the indications for the different types?
Right. Atrial fibrillation, and we look at something that's called, there's different scores, but the one that we use the most is the CHA2DS2-VASc score.
Okay.
And as a measure, and we look at risk factors. One of them is, and I'll start off with the touchy one, which is female sex. So if you have a CHA2DS2-VASc score of 1, and it's just because you're a woman, that is not considered really an effective risk factors. It is in addition to other ones, such as history of high blood pressure, history of some type of cardiovascular disease, which can mean a cardiomyopathy, it can mean having previous stents, having some other issues with the heart, diabetes. I think I may have mentioned hypertension, and age over 65. You get another point for age over 75.
Okay.
So those, if you have a CHA2DS2-VASc score of 1, generally you don't do much. You can do aspirin. It's not recommended.
Right after cardioversion.
No, we're talking even if you're in rhythm.
Right, but I'm saying
after cardioversion, no, you have to
so
have
you're in atrial fibrillation. You either get an ablation or cardioversion. What is your anticoagulant?
You have to be
regimen?
on some form of anticoagulation for a
month.
month.
So which one and how do you choose it?
Okay. Well, I would tend to use the newer agents. And there's two types of what they used to be called NOACs or novel anticoagulants, but now they're called direct thrombin inhibitors. There's Eliquis and Xarelto are the main ones. And Eliquis has the advantage of being a once-a-day medicine, but you have to take it with
it also drops platelets. I've seen a few patients where, why the hell are your platelets 60? And they stop the Eliquis and it comes back up.
Yeah. The other one is, I'm sorry, we're talking Eliquis. The other one is Xarelto, which is once a day and requires...
And what do they do?
They work on factor 10A, which is part of the clotting cascade, and it's very specific. And what's really interesting is that, yes, it can cause some bleeding, but the risk of bleeding on Eliquis or Xarelto is very similar to the risk of bleeding with aspirin.
I operate on patients on that. And as long as it's not a very bloody operation, I'm okay not even stopping
Eliquis and Xarelto? How far off? 24 hours or?
No, I don't stop.
You don't stop it?
Don't stop it. When I'm doing laparoscopic surgery that is not bloody, so it's not, it's more dissection of sewing. Like if I'm doing a hiatal hernia repair, I don't even need to stop it. Because the risk of a clot far outweighs the risk of bleeding.
Yes.
But if I'm doing a liver resection, obviously it's a different story.
Well, obviously. Yeah. And there's the other one, which is Pradaxa, which is a direct thrombin inhibitor.
Right.
The downside of that is it's hygroscopic. It absorbs water, so you have to keep it in this little pill container. You can't put it in your friendly pill binder, and because it becomes inactive, and also it can cause gastroesophageal reflux. So I don't use that nearly as much unless the insurance companies insist upon it.
Okay.
So
those are your three that you use.
Yeah.
What about Plavix?
Plavix, there is no real indication for atrial fibrillation. What's interesting is if you have atrial fibrillation and you've just had a stent, do you put someone on aspirin?
What does Plavix do?
Plavix it will permanently disable your platelets. As opposed to
platelet, when you say, "Oh my God," the platelets half-life is 10 days. They only live for 10 days.
Exactly. So that just means it takes out. The aspirin does the same thing.
Right. Well, aspirin is thromboxane A2 inhibitor, which does the same thing at a lesser level.
Yes.
But I've seen patients on Plavix and aspirin. That never made any sense to me.
Because you want to take out as much of the platelets as possible. And even with that, there are people that have differential response. That was one of the things I did when I was in academics, was looking at hematomas after device implants and seeing how people responded to Plavix. That's all we had.
But it depends on the general activation of the platelets. And that was my Ph.D., where sugar does that. Elevated levels of sugar, you're one of your most potent activators of platelets.
Yeah, which
those shape change very quickly.
Well, even though that was long beforehand, that's something I was not aware of when I was doing that research, because that wasn't really that out there.
No, and that's something that we studied in our laboratory. And then we're doing that as clotting in the liver. But, okay, so it's Plavix, and you'll use Plavix and aspirin sometimes.
We try to use it all the time when we're putting in a stent. Or we'll use Brilinta, which is even a more potent platelet inhibitor. Sometimes we can use Brilinta alone.
Right.
But the problem comes is if you have AFib, you don't want someone on triple agent, aspirin, Plavix.
Right, so you got no clotting function.
You exactly. And the Eliquis, ideally what you want to do is like stop the aspirin and just have them on, say, Brilinta and Eliquis, or Plavix and Eliquis.
So you're using platelets for what you call your white thrombus, antiplatelet for the white thrombus, and then for the red thrombus you're using the factor blockers.
Factor 10,
Okay.
Yeah, because unfortunately the risk of AFib stroke doesn't go down significantly with aspirin and Plavix.
Right. So let's ask two questions now. Let's say you've had a cardioversion, you sinus rhythm. How long should you stay on anticoagulation for?
Depends on what your CHA2DS2-VASc score is. We're going back to this 35-year-old guy that has only slight left atrial enlargement. We cardiovert him. He's on anticoagulation for a month. Put him on a little bit of metoprolol, and 30 days.
Okay.
Now, that's assuming he's got a CHA2DS2-VASc score of 0 or 1. So if he has a CHA2DS2-VASc score greater than that, that depends. For example, when your CHA2DS2-VASc score of 1, can you put someone on it? Yes, you can. If your only risk factor is hypertension, or your only risk factor is age over 65, a lot of times people don't want that. There's a little wiggle room. If you have the CHA2DS2-VASc score of 2, so you're a diabetic hypertensive, and unfortunately I've started counting metabolic syndrome as diabetes.
Yeah, I do.
As for the CHA2DS2-VASc score. And I think that's
I call it insulin resistance.
Yes. Yeah. So I haven't had an issue with that, but I really do think it's a risk, and that's the problem. The real interesting question is, what do you do if you put someone on a low carb diet?
Right.
And now you're getting rid of, and you're doing reverse remodeling. You're shrinking the atrium. You don't have as much fluid volume, and
well, that's where deprescription comes in.
Yeah, exactly.
But you say about a month if you've got a low score, and then
yes, more. Unfortunately, life. If once you have that diagnosis, the question is: was it a temporary thing? Is it from surgery? Is it from thyroid? But if we don't have a good reason, we will normally do a 24-hour monitor to start with, get insurance companies, and then we'll do an event recorder. Right. Usually I don't do more than 2 or 3 weeks because people get really irritated if you put something on them for a month. And on occasion, will we implant a loop recorder in them? And that usually is if we haven't found something, or we're having unanswered questions, like cryptogenic stroke.
Right. But the main risk there is that stroke prevention.
Yes, that's
as
the whole
opposed
reason
to heart
for this.
attack prevention.
It's primarily stroke prevention, but absolutely, you can have somebody die from a heart attack, classic myocardial infarction from big clot, but they just happen to have had AFib, and that's one of the things that it tends to go to the right coronary artery, and that's something I remember very well. Many years ago, even before I was a doctor, that happened to a family member. Wow. And only years later did I figure out, that was probably the atrial fibrillation, because they weren't anticoagulating people then.
So another question for you. Why do we not pay any attention to the right atrium?
We do. I do. I live in the right atrium and the right ventricle.
But I mean in terms of clot formation.
Because you have this wonderful filter called the lungs.
Right, but that's the question. I mean, your lungs, that's PE.
Big deal. You have them every day.
Right, and they're dissolving. But so a big clot going to...
Not likely. From the atrium.
Right.
But do we know? Because
you've got to measure it. Mm-hmm. And you don't measure those little guys. And you don't know if that's contributing pulmonary hypertension, all of those
it probably is.
Yeah.
But we don't have... it depends how good your lytic system is and how big they are. If you're an AFib, we haven't seen through measures of pulmonary, again, it's a tough study to do, but we would really be looking at pulmonary hypertension developing in unanticoagulated people, meaning people that have had left atrial appendage clipped, are not on anticoagulation. Now we're looking for the only place the clots are going to be, which is the right atrium, and we would have to track pulmonary pressures, which unfortunately, pulmonary pressures are not an exact measure, it's a range.
Well, stroke is a sudden event. It's a TIA or it's a stroke.
Right.
And it's a small clot that has a devastating effect. These little clots, we don't know what their cumulative effect is over time.
Oh, we do. In fact, that's one of the arguments for the CHA2DS2-VASc score and making it us more likely to anticoagulate, that we think that one of the mechanisms of dementia, it could be, other than like type 3 diabetes, but could be multiple microclots.
Right.
And that's probably
true. And there's VQ mismatch, a variety of different things there.
Yeah.
So what is the risk, or what percentage of people who are on anticoagulation, on atrial fibrillation, have a stroke?
It cuts the risk more or less in half. We look at the CHA2DS2-VASc score for risk. If you got a CHA2DS2-VASc score of 1, you're very, very similar to the average, which is a little less than 1% to 1%. 2, it goes into the 2 to 3 range. 4, it can go in the 4 range. When you get to be 5, it's about 5% per year or more.
Of a stroke. So now here's a question. If you have a Watchman or you have an atrial appendage clipping and you're not on anticoagulation, does that reduce your stroke risk below that? below the risk of anticoagulation?
No, it's the same. And that's the reason why a Watchman is not a first-line treatment.
Do you know how many patients I've had, just as a guy, who've been bullied into having a Watchman or bullied into having something done, and it's never been explained to them. And that data is so important that it doesn't improve your stroke risk.
Well, the thing is, a Watchman is about 95% as good as Eliquis or Xarelto. But not all of the clots form in the left atrial appendage.
But then you stop the anticoagulation, and now you're sitting with a right-sided potential problem.
Right, for pulmonary embolism. Yes, that's correct. But a lot of these people, either one, they can't afford it, they want to afford it, and the argument for doing a Watchman is a cost-effective one if you're young enough, not in the 88-year-old, but in a younger person that, well, this person's going to be anticoagulated for 20-some years. If we put a Watchman in and we're not doing that, we've saved a great deal of money, and the patient doesn't have to.
But if you look at people that have valve replacements, they're on anticoagulation for life.
Not for bioprosthetic valves, that's correct. For mechanical valves,
mechanical valves,
So, so it's about 95% is good, and the problem is that it's 95% is good. You can still have clots from other places.
Right, sure, of course.
In there.
And that's the value. The value for me also about being anticoagulated as opposed to having the atrial appendage taken care of is it reduces other clots.
Right, including the potential
DVTs.
risk with coronary.
Yeah.
And that's why very low dose Xarelto is used and may actually be better than 2.5 milligrams of Xarelto a day may be better than aspirin, because I know your definite concerns.
Right.
About
I mean, I certainly.
thrombosis.
Right. And also the other question is, does Xarelto then reduce your risk of? Aspirin is indicated, in my opinion, for plaque disease, but the contraindication is if you have a bleeding problem.
Yes.
Whereas Xarelto is actually probably slightly more tolerable from a bleeding issue
because of the platelets.
Because of the platelets. Mm-hmm. So low dose Xarelto, if it wasn't that expensive, might be a reasonable thing to do.
I think it'll be used
instead of an aspirin. What is a low dose Xarelto?
2.5 milligrams.
2.5 milligrams.
Mm-hmm. Yeah. And
aspirin, do you agree with me that aspirin is a good idea for someone with an elevated CAC score that's asymptomatic?
If you have documented disease, it's reasonable. The preventive services had the reasonable 40 to 60 preventive. As you get older than 60 or younger than 40, it's questionable. Documented disease.
They come up with these age-related things.
Yes.
Age is
documented disease.
Yeah.
If you have a calcium score, you've got disease.
Yeah. Well, that's what I'm talking about, a calcium score.
Yeah. If you've got anything greater than 0, you've got disease.
Well, I started looking at 80 to 100 as my threshold.
Yeah, and the issue comes down to they now have a number that's non-zero.
Because if you're on what you said earlier, if you're on a statin, you should be on an aspirin. Because statin scores plaque.
Well, no, the statins stabilize the plaque and they cause calcification.
Yeah, but if your CAC score is positive, you need to be on an aspirin. So if you're on a statin, you should be on an aspirin. Plus, you should be on a CoQ10. Plus, you probably should be on SGLT2 inhibitor. So now you're on 4 different medications.
Only if you have heart failure, possibly AFib for the SGLT2. So.
No,
I know you are.
Yeah. Okay. So. Another question, just another little side question. Bundle branch blocks, that kind of thing, can you ablate them?
You can, but you actually inadvertently asked a very interesting question. There is one type of arrhythmia. There's what's called a ventricular tachycardia. It's a bundle branch
like a
re-entry.
WPW?
It's not that. It's where you have a dilated heart.
Okay.
And you have one of the bundle branches is damaged. Usually it's on the left side. Mm-hmm. And it causes it's a resonant circuit between the anterior and the posterior fascicle. And that actually causes ventricular tachycardia. And you treat it by ablating one of the bundle branches, usually the anterior one. So, but you're already going to have some delay. It's a rare one, and frequently the EF is already low, so they end up getting a defibrillator anyway. Okay. But the bundle branch block, the only time you would want to ablate a bundle is in what's called an AV node ablation, where you're essentially ablating the AV node, which potentially turns off all the bundles.
Right.
And you do that if you have chronic AFib and you're trying to control the rate. So if you don't want to do a more complex ablation on a sick older person, someone with pulmonary hypertension, that has other
So it just
issues.
increases the block.
You put in a pacemaker, single chamber pacemaker, and ablate the node so the top doesn't talk to the bottom, and the pacemaker is doing all the work.
Next question for you, pacemakers.
Yes.
Okay. We know in my population, the ketogenic population, they often run slight bradycardia. So they'll have heart rates. My heart rate typically is in the 50s.
Yes.
And certainly it's below 70.
Unless they're on a GLP-1.
Yeah, we're not on
a little
that.
faster.
Yeah. Sometimes.
Yep.
But let's assume that you are metabolically healthy and your heart rate is below 70. Just as an assumption, and you have a pacemaker. Why do they pace at 70, not 60?
Most of the time, we do tend to pace at 60.
Most of my patients are paced at 70, which I've never understood. Now, it may just be Jacksonville or Jupiter, but I have... I always
Jacksonville, I know the EP's there. So.
You're tachycardic. You got tachy... I just had a patient of mine who he had a pacemaker originally, went into AFib, they ablated him, he did great, but they increased him from 60 to 70 as his heart rate. And it boggled, because he was always in the 50s. And it boggled my mind. So he was always pacemaker positive because he was running too low. But they assumed that the bradycardia was harmful, when I always thought the bradycardia was going to be as a metabolic bradycardia. He wasn't symptomatic when he was bradycardic. So you normally pace at 60, but I've got several patients who are paced at 70, and I've never understood that.
There can be a reason with dual chamber pacemakers to set a base rate. Sometimes we will set a sleep rate as well too, where the base rate may be 60 or 70 during the day, but when there's inactivity, it'll drop it down into the 50s.
But 60 is your number.
I will normally use 60.
Yeah.
If I have done an AV node ablation on somebody, then we normally set them at 80.
Because you atrial.
Because there's no atrium, it's just a single, and then we will slowly move it down and put a rate response on. Also, sometimes it can be because of the rate response being turned on, and it takes a slow for it to go up and slow for it to go down.
Right.
But generally, it's 60. If you have a single chamber defibrillator, a lot of times it's actually set at 50 because you don't want to pace the ventricle unnecessarily. So there is some variation of that, but generally 60 is the out of the box.
Yeah, it baffled me a little bit. That's always my understanding. And I've got quite a few folks from one particular place where one particular EP guy who's pacing at 70, and I never understood that. I'll tell you what his name is.
I think you're really going to like that Mocha.
So I just had that as a question, because this is a patient of mine. Why the hell are you at 70? Don't pace me at 70.
Right. What's normal heart rate? We use sinus rhythm, and I guess that goes back to Einthoven, 60 to 100.
60 to 100, right.
With anything faster than 100, because it's easy. Sinus tachycardia, less than 60 is sinus bradycardia. But from the EP perspective, going back to the days of Josephson, one of the old gods of EP, sinus rhythm should be 50 to 90.
Right.
And that's more physiological. And that sinus tachycardia is really anything over 90.
This is the name of the physician.
I'm not familiar with him.
Okay. So he's up in Jacksonville. Anyway, I just want to clarify that because I never understood it, but neither do you, which is good, the rationale. Anything else we should know about the electricity of the heart?
If your heart rate is really, really slow, you're going to feel bad.
What's slow?
You may die.
What do you mean slow?
Really, really slow generally means a resting heart rate while awake of under 40.
Okay, I'm not under 40.
While awake, under 40, unless you're a truly trained athlete. Inability to get your heart rate out of the 50s with exercise. If you're 70 years old and you're walking on the treadmill and your heart rate peaks out at 52, 53, and you're tired and you have to stop, that's chronotropic incompetency.
Okay.
When it comes to arrhythmias, we didn't really talk
I've got one particular one I want to ask you about, PVCs. We see a lot of them palpate.
Right.
So a couple of things. When a person's feeling their chest, the PVCs,
right.
You can measure that. What about PVCs, couplets, skip beats, all that kind of thing? Right. Tell me about those.
Skip beats is just a perception of something being skipped, where generally a PVC, and I like the analogy version here. It's like pre-ignition on a car. It's a backfire where the engine is pre-igniting before you have a good seal. So what happens is your ventricle is filling with blood, but because of one irritable spot, it now fires early. So the heart has not filled with blood, so it pushes out a third, a quarter of how much blood it should have, and also the mitral valve is open, so you get back pressure going up into your.
So you have regurgitation as well as
so just like with a backfire, where you've got your intake valve open while the engine fires, and it goes back into your carburetor. Right. That makes you feel funny, both in the neck and also in the lungs. So PVCs can be very symptomatic.
But when are PVCs a concern?
PVCs are a concern if they're more than 10% of the total heartbeats of the day.
Okay.
Because then that could go.
Even if they just occur paroxysmally, for a short duration, tick, 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 or you have got the PVCs, the abnormal beats, and then they go away.
I'm talking about the total amount in a 24-hour period.
So even if it comes and goes.
Right. If the total amount, if your PVC burden is greater than 10%, again, go back to the analogy with the backfiring. If you have it's backfiring too much, there's a certain point where it's going to damage the engine and damage the carburetor. 10% is where we can see it. Do I have people that have 20% that are fine? Their EKGs stay fine, their echoes stay fine, and I just watch them? Yes. But once you get to be 10%, frequently we will treat it with other antiarrhythmics or with ablation sometimes, depending on where the PVCs are coming from.
Is it a similar starting point? Is it a similar area?
No.
Pulmonary veins?
Back in the old days, before we had intervention, when we had a lot of people with total occlusion of coronary arteries and had large anterior wall MIs, and we had big areas with scars, we had a lot of reentrant arrhythmias where literally the PVCs would occur from a half live, half dead area, scar tissue, and then we would get a reentrant arrhythmia that could be fatal. Those PVCs were very concerning, very dangerous, and if you've got scar and lots of PVCs, that's one of those concerns we have. We look at revascularization, we look at a defibrillator, we do an EP study to see, are we going to induce a bad rhythm that'll kill you? The most common PVC, especially nowadays, is something called the right ventricular outflow tract PVCs. And in a similar way to the pulmonary veins, there's an area on the right ventricle, which again loads the lungs, and the left ventricle, called the outflow tract, where it's very similar, a near area where Schwarzenegger had his procedure, and that it tends to have irritable tissue, irritable cells. It's embryologic most likely, and that they vary in how often they go off on their own. They may decide, well, I'm going to start beating every once in a while, or I'm going to beat at 60 or 50. Usually antiarrhythmic medicines will help that. Sometimes if we really can't control it, or we're having very high numbers, or we start to see the heart is dilating, it's starting to show evidence that it doesn't like this, we'll then go in and we'll cauterize and do an ablation, a PVC ablation, which is a very successful procedure and gets people off of medications. But we don't have to ablate everybody. So most PVCs, I see a lot of people, a little more frequently women than men, that have PVCs, and we can tell by looking at the 12-lead EKG if it's from the right ventricular outflow tract. And I'll tell them that, hey, this is from the outflow tract, this is a benign thing, you don't have too many of them. I can put you on some metoprolol, I can put you on some verapamil, which frequently works well. We can try other things like Renexa, and if worse comes to worse, even good old-fashioned flecainide with an AV nodal blocking agent. There are a lot of options other than ablation. So ablation isn't needed that often, but it all comes down to symptoms.
And the value there is to be able to monitor that at home with a Cardia or a
one of those Cardia Mobile is great.
So there's something else I was going to ask you now. You've mentioned a few times thyroid.
Yes.
How does high or low? How does the thyroid affect the heart?
Hyperthyroidism.
High thyroid.
Which is high, can easily trigger atrial fibrillation. And I saw it once, it was many years ago. I'll say it in one of my medical school classmates, so it was not giving much of anything away, who was on, at that point, Armour thyroid extract, and he took a few extra. And this is because you got the free T3, T4, and he went into atrial fibrillation, went into the emergency room, and popped right out of AFib, and asked, "Were you on anything?" He said, "Yeah, I'm on my thyroid. Did you take it?" "Yeah, I took a couple of extra."
Okay.
So that's the best.
So you have to be
example.
very careful, because we a lot of doctors will, and I know it's a misguided thing, use thyroid medication to speed up their metabolism to help them to lose weight. I see that a lot.
Okay.
Why are you on thyroid medication? Oh, I've been on it for 20 years. My doctor put me on it to speed up my heart rate.
Right. That used to be done a
metabolism.
great deal. And the best example of that, it's like putting nitro into an old car. Will give you more power? Yeah, but it's an old car. It's 180,000 miles on it. You don't want to blow a head gasket.
Right.
So yes.
Hypothyroidism?
Hypo makes your heart rate slower. And it can cause fatigue and bradycardia.
But will it expose, will bradycardia expose arrhythmias?
Oh, that's good. Well, if you're hypothyroid and your heart rate is slow, will you have another type of arrhythmia? Probably not.
Okay.
But what it does is it makes you pass out. It makes you very fatigued. The question is, one of the things you're going to check with that, especially in a younger person, if it's just true bradycardia, sinus rhythm, heart rate of 35, yes, one of the first things you do is a TSH. Before you talk about a pacemaker, and then easy cure on there. But if
we do that. I mean, I do that. Yeah. I do thyroid blood work routinely, not just the TSH, but I do the whole spectrum.
Absolutely, T4 and free T3.
I do free T. Yeah, exactly.
I've watched your talks on that.
You know what? This has just been so illuminating, but my head is spinning. We're going to have to talk some more down the road.
That's
but
great.
I'm not going anywhere. Absolutely brilliant. Dr. Nabert, you've gone through a massive transformation since I've known you. It's been astounding, and the most important thing for me is it's been ongoing.
Yes.
Easy to do in a short period of time, but the consistency and the longitudinality of it, and it's getting better and better.
Yes.
Two questions for you. What changes have you personally undergone as a human being?
Mm-hmm.
And how has that impacted and affected your practice as a practicing cardiologist?
Okay. What changes have I undergone? I've over the last 2.5 years, I've lost 70 pounds since I've been low carb. I had previously been up another 20 pounds, and I had done protein sparing modified fasts and dropped down to do 60, and then went back up again. But I was so it's a total of 90 pounds from my highest. But from when I started, it's been 70 pounds. It was rapid at first, and then slower, and then I had all the situations that have occurred from the check mark type of a decrease in my weight to issues with sleep. Those got better, and I guess the big thing is when I started to lose weight rather quickly, and then when I was here last year, I was about 35 pounds still heavier than now. And I've got about 30 pounds to go back to my Air Force weight. That I was, people were noticing a lot of things. And I've had people that, my patients, are saying, well, what's going on? And I leave the old fat picture up in the office.
Yeah, it's pretty astounding. It's pretty impressive.
So when people, do you have cancer?
Yeah.
I had one person ask me that.
HIV and cancer.
And I said, no, I just stopped eating. Like, you did? Like, no, I'm a low carb. And then I put together a nice packet of about 8 pages, combined things from you, from Eric, from a number of other people, low carb down under, and I'll give them my.
So you've created your own handout of, hey, this is what I'm doing.
Yes,
wow.
And I'll do that, and then a lot of people will ask me, but I now start talking with people, because some people were afraid to say anything because they say, oh no, something's wrong, and I injured my leg, so I've actually done this without exercise.
Right.
So I'm working with a cane for now, but that should hopefully be eliminated in a not too distant future.
Yeah. But that's an important point, is that while exercise, you are more physically active, you're more mobile because you're less heavy, but you're not intentionally exercising.
Right.
So this is the metabolic transformation.
Mm-hmm.
And in terms of medication and that kind of thing?
I'm really not on anything but Flonase.
What were you on before?
Well, I had metabolic syndrome, I had hypertension, and I took statins, and I'm going to be very cautious about on there, but to simply say that I feel that my lipids are significantly better, and since I went on only as an N of 1 experiment primary prevention, I feel my lipids are sufficiently good enough that for me, with no documented coronary disease.
And that's the key thing, is that your risk is low
Right.
either way.
Yes. That I don't think adding more medications is necessarily going to be helpful.
So do you take any anticoagulation?
No. I had been on an 81 milligram aspirin. I'm off of that right now. And like I said, I'll use Flonase for my allergies.
Wonderful.
And my blood pressures run between 100 to 110 systolic, over 70s. And that's where it was when I was in college and med school.
Let me ask you a question. You mentioned that you had hypertension. We've talked about that in the previous segment.
Right.
Have you ever had an echo?
Yes.
Have you had an echo recently?
Not within the last couple of months.
Has your echo changed at all?
Yes.
In what way?
It's changed.
Better?
Okay. Yes.
Okay.
I'll give you that.
So
because I know this is my private medical stuff that's going.
I understand your no,
thousands of
right, I
people.
understand that, and really, it wasn't about promulgating anything, but the question is, can your heart improve as you improve your metabolic risk?
Absolutely.
And you are saying that yes, you have documentation to say that your heart has improved.
Yes.
From which is a big deal, because you're obviously off your antihypertensive medication.
Right.
So as your blood pressure gets better, because you've improved your metabolic state and you've lost weight, and I will give both of those equal weight. Your heart has improved.
Not my just A1C is 5.3.
Right. So all of those things,
use
and you've
my
got
Dexcom.
your Dexcom. So you're monitoring, you're managing, but the improvement in your cardiovascular really anatomy and function is a big deal. And yet you are still able to get your blood pressure up slightly and your heart rate up slightly when you need to.
Yes.
Wonderful. And why do you think that happened?
Because I was most likely insulin resistant from the time I was in, I won't say college, but medical school, when we first started checking our lipids. And I was running LDLs in the 130s and HDLs in the low 40s. But my triglycerides were in the 160s. I couldn't figure that one out. I thought I must have eaten too many eggs. So I think that it was probably by that time insulin resistance was starting.
But you're attributing this to insulin resistance despite the fact that you've lost about 90 pounds.
Right.
So it's not the weight. Because a lot of people say that happened because you lost weight.
When I had those lipids and I was 25 years old, I weighed 160. So I'm still 30-some pounds more than I was then.
Yeah.
But my lipids are better than they were when I was 25. And 30 pounds less.
Better is there's a difference of opinion whether they're better or not.
My triglycerides are lower than they've ever been.
And I don't think anybody's going to argue with that. As a cardiologist, what are your ideal, forget about the metabolic side, what are your ideal triglyceride numbers, just triglycerides?
Triglycerides, preferably equal to the HDL.
Okay, so I use 75.
Yeah.
So you want that to happen.
We definitely want it under 100.
And there's no ambiguity. In cardiology, there's no ambiguity about that. Am I right?
Yeah, no, that's correct. It's good to have triglycerides under 100, and it's good to have HDL over 50. That's absolutely agreed upon in cardiology.
Right.
The issue is LDL and ApoB.
Okay.
And those are the big areas of that.
The contentious side. I don't want to get contentious with it, but it's nice that there's synergy with HDL and
yes.
And the one that they don't ever really consider very much is VLDL.
Yeah, and I didn't pay attention to it until I started following you, and I understood the mechanism beforehand, but I didn't really understand the mechanism.
And what is your attitude? Because again, a lot of the advice we get commonly from cardiology is reduce salt, reduced fat. What is your approach to that in your own life and with respect to your patients now?
Well, in my own life, my mid-levels, my nurse practitioners and my PA sort of laugh because I've got a nice shaker of salt A clear one, that's my that is a Himalayan red salt. Now I don't have Redmond's,
Yeah.
but actually that Himalayan salt tastes really good. And I came off the last of my blood pressure medicines a while back. I was surprised how long it took for.
It does take time.
Yeah,
Yes.
with insulin resistance, and
Yes.
then I mean I was hypotensive for a little while, and then a couple of days later, boom, I was perfectly fine. But I always was having salt, and on my fast days, I'll have 2 bouillon cubes. So I'll make sure about that. So I noticed that no pedal edema.
Well, let me say, isn't it true that cardiologists focus very heavily on salt reduction
Yes.
because they don't focus at all on glucose reduction? And both are hygroscopic to the same
Yes.
extent. Whereas on the ketogenic side, we focus on the sugar, and therefore you need the salt.
Right. Well, I differentiate with my patients. And when it comes to what should I do about salt, like, well, that depends. Are you on a standard American diet? If you're on a standard American diet, the standard is that
You don't want both.
We reduce your salt intake. It will, if you're in heart failure, you have the diagnosis, you have hypertension, we need to reduce your salt as long as you're on a standard American high carb diet. If you choose to be on a low carbohydrate diet, we will be able to probably add salt at some point. But if you truly restrict it, then first thing is we're going to have to cut back on some of your diuretics. So it depends on what time. I'll tell them, this is what a low carb diet is. Now we start with less than 50 grams a day, and sometimes you have to go. I had to go to 20. I really had to go low.
Yeah.
And
that's, you and I are both obesogenic.
yes.
So we are. I mean, we don't socially distance from a donut. We're gaining weight.
Right. Yeah, that's a joke I have with one of my partners. Is, here, David, have a farciga and a donut.
I like that.
But in all seriousness, we do shared decision making. So if you are interested in trying this, and I tell them I'm actually a rather freshly minted metabolic health practitioner, but I've been doing this for a few years now.
And you've got the story to tell.
Yes.
You are the evidence.
So we discuss the options, and there's a lot of people that can't give up their grits.
Of course. And you know what? Look, we're all going to die.
Yes.
How we get there is our choice. I can choose to take a statin or not take a statin. I can choose to not eat carbohydrates or not. That's my choice.
Right.
But I need the information on both sides of the equation to make the best decision for myself. Yes. And sometimes we're prevented as lay people of having all the information we need to make the right decision.
Right. I'm going to make one more comment to really get short on disk space here, is that I really need to let you and Eric Westman know. You both have been my mentors. I have learned a tremendous amount from both of you over the last few years. I like to say, when I watch your talks, it's like my first 2 years of medical school. When I watch his talks, it's like the second 2 years of medical school. So I'm back in school again. And I really didn't realize how much I didn't know. And it is something that is so... I didn't think at my age that I would have such epiphanies on things. There's so many things we can talk about in the future, but I will say one thing to one other person who I can actually safely say saved my life, and that's Nina Teicholz. I told her that last year when I met her. She didn't believe me.
She wrote The Big Fat Lie.
She wrote The Big Fat Lie, and I accidentally stumbled across it. I was looking up a cardiologist whose name was very similar to hers, and then I saw the book, like, wait a second, that's strange. And then I looked, and there was next on Google was the YouTube from the Cato Institute talk. So I watched the Cato Institute talk, and then it was, oh my God, this is all starting to make sense, because all doctors have a bundle of things they don't understand and want to understand. With me, it was diabetes, hypertension, gout, asthma, and obesity. I didn't realize they were all basically a manifestation of one disease.
They're the consequences.
And when I saw that...
But you're inquisitive about it. If you don't have an open mind, you're not going to see that. You're going to pass by it. And that's... I really am humbled by what you said, especially for someone that's as highly trained as you are. It really is humbling. But
well, EPs are just as arrogant as surgeons.
Well, exactly right. No, more so. Cardiologists. The only ones that are worse are the CV surgeons. But and I worked with Chris Barnard. So
doesn't surprise me.
Yes. But I really am. You know, when you and I talk, I've always got to be very super cautious about your level of knowledge, your level of understanding. And yet, and I have that imposter syndrome tremendously, self-doubt.
Yes.
And yet your results have just reinforced. If someone like you, someone like Phil, Ovida, folks that are entrenched in what I believe the wrong direction, have been able, with caution and with science, to be able to change your perspective. Art Agatston did the same thing. He's just bastions of leadership, because you're changing yourself, but also changing the narrative in your own practice and in the cardiology space, which is only going to better our patients. So it really is very, very impressive as a journey.
Yeah. Well, as my journey continues, I'll be glad to talk to you again next year or whenever, and
we'll
give you more information.
I really appreciate this. This is wonderful.